directly. At this time, I'd like to turn today's program to Canada Health Infoway. The floor is yours.
And good afternoon to everyone, and I'd like to add my warm welcomes to our delegates who are joining us from right across Canada, and indeed we have some international delegates on the line. My name is Mark Donadovic. I'm the Group Director of the Emerging Technology Group at Canada Health Infoway, and we are your hosts today. I am the moderator for today's session, and this is indeed our third in a series of webinars that we are performing on emerging technology topics. A few housekeeping notes that I want to share with you before we get underway. And Dennis, if you could advance the slide to inform everyone that we are recording this session. The purpose of that, of course, is for future use for education purposes, both internally with our audiences and, of course, for your use with your external audiences. We heard some notice around our question and answer format. Please use the chat box. I, as moderator, will be presenting your questions to our two guest speakers, who I'll introduce in a moment. For you to start typing your questions as they come to mind during the presentations. That way we'll avoid any pregnant pause as we transfer or transition from speaker to the Q&A session. Please use that chat function. I want to move to our disclaimer. Thank you for putting that up. Just really key points here. The webinar is a reflection of the views of Canada Health Infoway and particularly of the speakers who are with us today. Should not take away from this presentation any indication that this is representative of future strategies or investments that Canada Health Infoway may make in these areas. And that a reminder, we are vendor agnostic. We may mention in our webinars and in today's webinars certain vendors or certain products, but they are for the purpose of illustration and they are not for the purpose of endorsement. I'll tell you about the Emerging Technology Group for those of you who are joining us in this third webinar. We formed a little over a year ago, and the purpose and the key mission for the technology groups is to identify and assess emerging health ICTs. And our view there is that we want to find emerging and disruptive technologies that may be adopted by the health sector to support the delivery of healthcare in Canada. Our vision is to identify those emerging technologies and just how they might be used effectively to promote the health of Canadians to sustain the healthcare system. Today's session. This will consist of two presentations on two emerging standards in their very early days, but promise to be of value for interoperability in Canada. We'll start today's presentation on CIMI, or better known Clinical Information Modeling Initiative, pronounced CIMI. That will be by Dennis Giokas, who I'll introduce in a moment. The effort of CIMI aims to define a shareable, implementable data and information model for small, discrete clinical concepts that are used for various aspects of information technology systems. This presentation will be followed by the second presentation that will be led by Ron Parker, and I'll introduce Ron as we transition to that presentation. Ron's presentation will be on Fast Health Interoperability Resources, FHIR. This is a standards product from the family for Level 7 HL7 that is positioned to allow rapid deployment of reliable and consistent interfaces between systems. So we get started with Dennis's presentation. For those who don't know Dennis Giokas, he is the Chief Technology Officer at Canada Health Infoway, and he's also the Executive Leader of the Emerging Technology Group.
Thank you, Mark, everyone. I'm going to be speaking to the Clinical Information Modeling Initiative, as Mark said. Let me just give a little bit of the backstory as to how this got created. We were formed about 2 years ago as a result of work that HL7 was doing. I was part of that. It was a task force set by the board of directors at HL7 to look at HL7 V2, V3, CDA, and any future needs that the organization might want to pursue in support of the interoperability agenda around the world. Stan Huff was our chair of that task force that I was a member of. And as a result of that, we saw a very strong need to establish clinical models that could be used in interoperability. We felt that was a gap, that well-defined, curated, and managed and open clinical models were not available to the broader community for all types of uses, hence the formation of this group. It stands right now, CIMI is an independent initiative. It is not part of any SDO. How that might play out in the future is still undetermined, but right now we're staying independent, running very lean and mean, effectively with little or no budget, and hold our meetings pretty much at the will of those who can donate space and even in some cases donate food to support our meetings. So without further ado, let me get into the material. Brief agenda here. We'll go through the overall mission and goals, what is in scope for us, why do we even need this new paradigm. As a result of this paradigm, we're defining a few models, which I'll define for you, both logical models and isosemantic models, update on the status of the initiative, and our views at this time around the implications for Canada. Simply, our mission is to improve the interoperability of healthcare systems through shared implementable clinical information models. Now, there's a lot behind this statement. I'm actually going to take it from the back end of the mission. Our focus is just on clinical information models. We're not attempting to define how those models are used in any implementable sense, although it's very important in our work that they be implementable through any number of means, and I'll show you what those are in a few minutes. And it's not just about interoperability either, so think of interoperability in the very broadest sense. We want these models to be shared. We want to define them so they can be used by literally any country, so we will take a view of many models applicable on an international basis, but we all know from all work in standards that many of the work that's done internationally does have to be realm localized, and we are wise to that need in the case of CIMI as well. So our goals are basically 5. We want to certainly meet the needs of the clinical modeling community. We have a very broad-based group of folks ranging from modelers to information modelers to tooling specialists, clinicians, really from around the world, representation from Canada, Australia, Singapore, Korea, the United States, England, Denmark, Sweden. A lot of countries are participating at this point in time, effectively donating their time and intellectual capital in support of this initiative. As that, we want to share these, and we will stand up at some point a repository for sharing these models. We have to base them on a single formalism, and we have chosen OpenAIRE as the starting point for our formalism and the starting point for our reference model for the definition of these. And we're using 2 really tooling stacks at this point in time. Archetype definition, which otherwise known as ADL, is one tool, and we have plans to make email available and make those 2 tools hopefully interoperable in a sense as well. So the end user who's modeling and maybe transforming these into implementable artifacts can use their tooling stack of choice. We focus on a common set of data types, probably leveraging off the ISO set of data types that have been established by a number of SDOs. A very important goal is formal bindings to standard coded terminologies. We see this as a very big issue in the context of the terminology SDOs doing their own thing and interoperability SDOs doing something a little different, and we call it the impedance mismatch between the two. And one of the things we want to solve for is that impedance mismatch, and I'll elaborate on that in a bit. Another key feature of what we're doing is this is free and open and available for anyone to use through the repository, so we don't want any IP encumbrances for any SDO that might be downstream, any vendor, or any national or regional program that might want to use these models to be encumbered by any IP restrictions or even any cost. Some of our key principles, one is we are about implementation. We want to make sure that these models can be implemented. We use the words in a popular technology stack that is in use today. So we will look at any number of things that fall into that phrase, a popular technology stack. It could be a programming language, it could be a database, such as a relational database management system, or it could be a technology stack, if you will, that's used for interoperability, such as OpenAir or HL7 or something else that might not even exist as of today. So we want to make sure that anything we do is implementable. We want to be very practical and pragmatic in the work we do. And we can do to make them easy to implement through tooling or any other means, so we will do that as well. We will look seeing things of value, and our first principle is make sure it's just good enough. So we want to approve a good enough reference model, data types, other aspects that go into the definition of these models, and be very, very practical in that context. We have an editorial board that we will establish in the context of this, so they will be our light, if you will, and if you steer this effort in that context. And then we will need experts, primarily clinicians, but some modelers as well, who will actually curate these models before they go into the repository and curate them in the context of maintenance as well. So we want to model, as you heard me say earlier, interoperability in the very broadest sense. So clinically, we want to model a number of the things that you see on these screens. This screen, I'm going to read it to you. Maybe some things that we should be modeling that's not on this list as well, but we have a very broad scope as to what we would consider modeling on a go-forward basis. And just to put it into context, Intermountain Health, where Stan Huff happens to be the CMIO, has spent a number of years doing modeling for their own clinical initiatives. And you can see the number at the top of the screen there, 4,384 clinical models have been created by Intermountain. And that just gives you a sense of the scale of this effort that we are undertaking. So in my personal view, I don't know how any one health system or any one country could undertake an initiative of this scope and scale without partnering. So our goal is to create that community interest for the benefit of those care delivery programs, vendors, and certainly clinicians, and then all of us as patients of the health system. Our contexts are very broad, so it's not just about interoperability in the sense of messages that might have to be transmitted between any two systems, although that is clearly in scope. We could add documents and clinical statements that might be documents that might be exchanged to that modeling context as well. Other contexts that might not be obvious are services or service calls. So, for example, if I'm calling a DUR algorithm that's in a drug information system, what am I passing it? What is the clinical model for the information that I'm passing it? Maybe in this case, that clinical model is representing the drug I want to prescribe, and my current med list is already in the DIS, so I don't need to pass that. But that service call requires clinical information, and so I could use these clinical models in the context of the parameters, if you will, that I pass to these service calls for execution. Certainly could be used for data storage. We could use these in decision logic. So if I need to pass clinical information to a decision support algorithm, what information in what form, using what coded medical vocabularies do I pass it? Those models could be used in that context as well. Take a model that, let's say, represents something like a medication as an artifact that I'm viewing, but I could also morph it into an order. The elements as to how I would describe that medication, dosage, route, the actual medication, the instructions for administration, all of those things may be in the clinical model from a view perspective, but as I said, I could morph it into an order as well, which lead to data entry screens, reports. Maybe these models are used in a context of clinical trials. And last but not least, but a very important consideration is using these models in a secondary use context, and in particular for analytics. So, logical model. It's a full information model of a clinical concept, and I'm going to draw upon a model we use a lot in our meetings, which is a blood pressure, to kind of bring this to life for each of you. So, an example of blood pressure is something we will model: lab observations, medications, procedures. All of those things that you saw a couple slides back can all be modeled. The logical models, we need to show the structural relationship of those model elements, in other words, containment. So I'll give you some examples. This is me speaking in the context of these models using blood pressure. So systolic and diastolic may be what I measured. So that may be one structural relationship. How I took that blood pressure may be another set of model elements, such as what was the position of the patient? What was the blood pressure cuff size? Where was the blood pressure cuff placed? Are examples of model elements that may get into that measurement component. And then the state or status of the individual. Are they, what is their position? Are they in a resting state? Are they in an exercising state? So that may be another aspect of structural elements, model elements that fit into that structural element that represents the patient. So it just gives you a sense as to how detailed we could be with respect to something that on the surface seems very simple, a blood pressure, but a lot of other attributes or data attributes that might need to be recorded in certain clinical contexts. How for and define the explicit bindings to coded values. So those may be very constrained lists like H7 value sets. They may be full-fledged reference terminologies like SNOMED CD or LOINC. So we will define our preferred vocabularies in the context of these models. Define data types for each of the data elements in that model. Specify a single unit of measure. And I'll tell you a little story about this one. There was a discussion between someone from the UK and someone from the US when we were talking about temperature. And the person from the UK said, well, what is our unit of measure? And well, the person from the US said, well, what do you prefer? He said, well, I prefer centigrade. And the person from the US, you would think, would prefer Fahrenheit, but the person from the US says, well, I don't care. That works for me. And in this context, we probably shouldn't care, since we can mathematically and very easily transform from one to the other and back again. The models were to support some processing knowledge. So in the context of that blood pressure, there may be some recommended defaults. So maybe all I need as a clinician to input is measurement observations, systolic and diastolic, and the other things are assumed, and we can define the defaults for those assumed values in absence of them being input in the context of the model, and those would be agreed upon and curate elements as well. I wanted to find examples for the models so they can come to life with real-world examples, and then sure they're independent, but the implementation, such as an interoperability standard or any particular database design or structure, but our goal would be to test these out in implementation scenarios to ensure that they do work. There's a bit of an impedance mismatch between terminology and information models. We tend to see models made by data modelers, such as messaging standards, and we see our models made by terminology groups and the maintenance of term relationships between those terms. And often the two create this mismatch or this dissonance that somebody has to resolve later. And what we hope to do in the definition of these is either eliminate that, or in the context of the models that are kitted, resolve it. And I'll show you some examples of that when we get a little further on into this. Another concept that we have recognized the need for to define as well as solve for is what we call isosemantic models. And an isosemantic model is where you have two or more models that, while different in structure, do represent the same semantic content. Some of that to life as well with a few examples, complements of work that the Singapore Ministry of Health Holdings did. But before that, these models could be variable because they're used in a different user interface paradigm. It could be variable in the context of how I store that information in a database. Typically, where we see most of the variance is in whether certain controlled medical vocabularies are pre-coordinated and post-coordinated, and that's the essence of what I'm going to show you in a minute. So here are three screens that are dealing with input from a clinician for a diagnosis of suspected lung cancer. And these have to be three screens in different clinical settings. As I said, this is complements of the Singapore Ministry of Health Holdings. The screen on our left is representing those three aspects of this as discrete data tree fields. In the top two cases, drop-down boxes, and in the bottom case, a set of rate buttons. In the middle screen, the problem diagnosis and the body site, the problem diagnosis and the are in one field, and the body site is in the field below it. And in the far right, in that screen, you see all the elements are in one drop-down list. They all mean the same thing to the clinician, to those who might be downstream from this data and having to process it. But there's implications in the context of what we need to do from a modeling perspective and how we might model it. From a database perspective, take those key examples again. You see them as basic columns on this visual, and then the rows representing what could be organized in a database. You know, I want to break these three concepts up: the fact that it's cancer, the fact that it's in the lung, and the fact that the concept is suspected are three independent data elements in three different parts of that database. Why in the other two cases they may be pre-coordinated and stored, if you will, in one row and one column in that database. Another is in the context of SNOMED CT. You see at the top of the screen here what's known as the compositional grammar for problem diagnosis, where it outlines the problem diagnosis name, the body site, the laterality, the severity, and the finding context. And what's done is below that is shown the three views that you saw in those three user interface designs represented with correct compositional grammar using SNOMED CT again. And in this concept, the top one is fully post-coordinated and the bottom one is fully pre-coordinated. So this is going to bring to life what an isosemantic model is and some of the challenges we have in defining these and deciding when it's appropriate to pre-coordinate and post-coordinate and how to use something about SNOMED CT in the context of defining these clinical models. We'll only include them in the repository when we see that they're useful. In that context, too, we will have the preferred model that we would recommend be used and the others that might be isosemantic to that model, if we find that are useful, would be there as secondary models that could be considered for any number of purposes. I hope to have very well-defined transform rules so that one would know how to transform from one to the other in a deterministic way and back again if that were necessary. So, for example, if I'm dealing with pre-coordinated SNOMED CT terms, you know, how could I represent the same thing in a post-coordinated view as well? Is a big aspect of what we're doing in the context of the work we're doing, and we've settled on two terminologies of choice through our meetings and through actually voting. SNOMED CT has been decided will be the primary reference terminology where it has the concepts we need. If it doesn't, we'll look for other terminologies to fill that gap. Secondary, that will be LOINC, and that would be our second choice if it's not in SNOMED CT. And if there's an overlap, SNOMED CT would be our first choice in that context as well. And if we see a need in terminology such as SNOMED, CT, or LOINC, we will propose extensions to those, goes to the SDOs responsible for those terminologies, recommended inclusions in their next release, but if necessary, maintain our own extensions so they're accepted by that terminology organization. So just very briefly, some conclusions about where we are and implications for Canada. It's still much in the early days. We are really operating on this shoestring. About 3 times a year, formally face-to-face meetings that typically last 2.5 days. It's very much a multinational initiative, as I mentioned earlier, with a number of countries participating. And right now we're still independent of any formal SDO, and we intend to stay that way in the near term until we get a little further along in our work. Our effort has been focused on the process, on tooling, on governance, and even the feasibility of what we're doing. So we've started to develop models using the tools based on real-world needs and real-world contributions. For example, Canada has contributed some of the models we've done in our messaging context as a start point for some of the models we're doing here in the CIMI context. And other countries have done the same thing. So I am very optimistic that this can succeed and generate real value. It's still very early days, so I won't say it has generated real value and will succeed, but I'm optimistic that it can. And our role from an Infoway perspective is to participate we can add value, influence the agenda, as we're doing today, advise you, our stakeholders, on the initiative as it progresses and keeping you up to date with respect to that as new needs arrive. So going forward, I see myself certainly backing out of this. I will exceed my ability to contribute once we need to get very strong and focused clinician participation. When we get to that point of taking these international models and contributing to them and then curating them and then hopefully localizing them to some Canadian use. And again, it's a very broad-based set of uses that you saw a few slides back. Wiki, compliments of Mayo Clinic. There's the link. We'll be pasting that into the webinar later so you can have access to it, and it'll be made available to you when we make these slides available. So that's the end of this on CIMI. I'll pass it back over to Mark.
Dennis, that was a very informative presentation, and I'm sure as a message to all of our delegates that you probably have questions for Dennis. I would ask that you use the chat function to record those questions, and we will pick up on those in the discussion period following the second presentation. That second presentation I'd like to introduce now, and its speaker is Ron Parker, who I'm sure you can see up in your screen now. Welcome, Ron, to address today's second topic on Fast Health Interoperability Resources, the acronym FHIRE. By way of introduction, Ron is also a group director in the Emergent Technology Group, and he's an active contributor to the Canadian and international health standards communities. He is the vice chair of HL7's Architecture Review Board, and he's elected chair of HL7's FHIRE Governance Board. So Ron, please introduce us to your...
Thank you. Next slide, Dennis. So quick window, we'll talk a little bit about Health Interoperability Resources, otherwise known as FHIRE, summarize its key features, talk about the governance and management model that we're using for the evolution of this product set, and also consider a little bit around the current state and the future direction and some of the implications for use in the Canadian healthcare context. So with the premise, we've been working in the standard space for quite a while around system-to-system communication, and with very strong focus here on what it takes for computer systems to interact, to interoperate, to be able to move information around. And it's been complex. In a lot of cases, developing interfaces can be slow work. It takes knowledge, specialist skills, tools. Some of the work that's been developed requires a significant investment in terms of your ability to understand it in order to be able to use it. And as a result, it can be a bit costly. So the question was developed to answer is, what if it didn't have to be like that? And perspective, FHIR has been developed explicitly from a developer's point of view. In other words, from someone who is responsible for developing interfaces between systems, what would be an ideal way to approach solving for these challenges associated with interoperability in a way that would be readily implementable by developers. So, a little bit of initial work. We've set on there's a product been brought actually to HL7 by a proponent and then adopted by the organization to be managed under its context called Fast Health Interoperability Resources, or pronounced FHIR. Based on industry best practices, there's a big focus here on simplicity and ease of implementation. Technologies that are already well established and exist. And all key feature is that regardless of the degree of sophistication of the systems that use FHIR, at the very least, we provide capacity in this standard to have human readability. So that's the foundation. The other important aspect of this artifact is that there's one syntax which can be used to represent concepts like documentation, messages between systems, invocations in terms of between systems, and what are called RESTful interfaces. So representational state transfer is what that acronym stands for. So this syntax has computable templates and profiles that will work in all kinds of application architectures in terms of being able to communicate to support the transfer of information from point to point. Another key thing that we want to emphasize, and Dennis has done the same, what's very, very interesting in healthcare is that, particularly in the standards domain, it is a small community. It's not a large group, and there's a lot of cross-pollination that occurs, and that's to the benefit of everyone, and FHIR is no exception. It is truly international in scope. The original proponent from a developer perspective is Australian. The core team has been developing the initial proposal as well as the subsequent core work that's been happening on the infrastructure for this standard. It includes representatives from Canada and the Netherlands, and the contributors and implementers from many additional countries in the early stages of this, including Italy, New Zealand, the United Kingdom, United States, and others. That's fundamentally about is this word resources. So Fast Health Interoperability, you sort of get the sense of that. That's really the sort of design, the goals, if you will, of what it is. But really, ultimately, it's around this idea of defining things called resources. This language will be very, very similar to what Dennis just described in the sense that these are small, logically discrete units for exchange. Now, the heavy emphasis here is that this is for exchange between systems. When Dennis was speaking earlier about semi-representation, he was speaking very much around concept representation and an ability to support interoperability in many dimensions, whether that's between humans, between systems, or frankly, even between humans and the computers that they work with. Very will support that, but is very strongly oriented towards the ability to exchange. These resources has a defined behavior and meaning to them. They have own identity and location in terms of where these resources reside, how you can access them. And we try to characterize these as the smallest unit of transaction of interest to healthcare. So again, some examples of our resource are the concept of a patient and how that's defined, provider, specimen, drug, result, allergy care plans, and adverse reaction. Now, in 3 parts, there is defined structured data, so the logical common contents of the resource, which maps to formal definitions. Now, this is the interesting thing as well. This is a FHIR asset, and because many of the, an HL7 asset, because many of the team, our team members are working in that domain as well. There are definitions that we are deriving from the reference information model, which is an HL7 product, but there are other places that we are drawing from in terms of the definitional work. There are extensions. Now, extensions are local requirements for the use of a FHIR resource, but frankly, done in such a way that anyone can use them. So the extensions are discoverable broadly, be able to be adopted by others, and potentially adapted for particular use, and they are published and managed along with the formal definition. Finally, the third major component is the narrative, and this is the human-readable content associated with any resource, supposing that the systems involved can't actually parse the other aspects of it. At least they can present that human-readable information in an interface. An example of these three things. So you have the reference information, you have the human-readable summary, and the standard content. So along with the extension. So the key thing here is if you have any familiarity, for example, in working with an HL7 v3 paradigm, this is very, very similar to constructs done in that paradigm, but you'll notice if you look at this, this is an XML representation. It's extremely compact. And one of the that we had in the v3 world, which was one we developed those XML formats in a very robust way, derived from a reference information model. It used a tremendous amount of inheritance from the model and it required a lot of expression, if you will, nesting of components of the XML to fully express the thing. And what Offert is attempting to do is to say, you know what, we can actually take that same content, represent it in a more condensed fashion, still lose any of the value of the meaning or of the modeling for that matter, but still able to present it to you in a much more concrete and simple way. And that's and then what we will do then is standardize around that representation. And that's really the foundation of Offert. Now, the extensions. One of the philosophical basis of Offert is resources are modeled. The idea is not to attempt to model every possible nuance, variation, and flavor of a thing. In other words, they often use using that old soft 80-20 rule. You know, let's get the resources as we've defined them suitable for 80% of implementations to our assessment. And of course, that means over time. But the key thing is that's an operating principle in terms of the way things are defined. To Offert credit, the other thing that they've done is that they've developed this concept of extensibility and recognizing that that 80% rule isn't going to work for everybody all of the time. Necessarily having to spend % of our time solving for those 20% of exceptions or variation. Rather, the model has built in an inherent ability to support extension and be able to actually manage those. Next step. So Offert means extensibility by providing at an engineering level an extensibility framework. It helps solve for this problem by defining those extensions, publishing them, and allowing discovery of them, and then for subsequent use. So if people refine that 80% resource and make it specific to a particular scenario, in the course of doing so, based upon the way that the technology has been architected, you will be able to discover what those extensions are and potentially reuse them, and certainly at the very least be able to understand them. Now, another really important thing, and this was not a small point actually in terms of the bringing of Offert into the HL7 domain, is that there was a real desire to have this asset inside a standards, a consensus-based standards body that is accredited. That's the thing. And really where the asset would then be managed carefully, protected, so that people that invest in it have a sense there is a forum within which change is managed, where new things are created, and that the governance of these things is transparent and well structured. Now, 7 has actually done a lot in the last 2 years around innovating a new approach to how to manage HL7 products. And this new approach clearly separates the role of governance in terms of products as an asset, the management of those products, and the methodology used to produce those products, as well as to determine to do conformity assessment in terms of the nature of the quality of the resulting products and how they're applied. Now, what's interesting about this, and this is from a Canadian perspective, Canadians are strongly represented in all 3 dimensions of governance, management, and methodology for Offert as it evolves. It's an important thing to know. State of Offert, we have a thing called Connect-a-thons, and this is all an innovation for HL7. HL7 has supported the concept of draft standards for trial use for quite some time. We've taken a page, although I would say quite a bit more informally, from other organizations, and we submit each of the 3 working group meetings a year, and we've been doing this now for a little while, the ability for participants to come and attend beginning on Saturday each of these meetings, these Connect-a-thons. There's been 2 Connect-a-thons so far. There have been about 20 plus implementers that have shown up. There are multiple reference implementations as a result of FHIR. So there are people that have actually stood things up and systems have interacted. Focus to this point has been largely around getting the infrastructure and the basic structural elements of FHIR working and confirmed and validated. But the other interesting thing is that there are auto-generated interfaces out of the FHIR resource definitions in 4 computer processable languages. So .NET, for example, Java, and others, C#. So there are implementable specifications actually arising out of this that people that might want to consider looking at this emergent standard can actually use. There are servers that you can connect to if you want to build an application and try it out. These are publicly available. And just so you're aware, there's also some significant collaboration happening with something called the Integrating the Healthcare Enterprise, otherwise known as IAG, and so Digital Imaging and Communications Standard for Medicine. Both are exploring the use of FHIR in terms of things that they may be able to do with this paradigm. So that's interesting. And then the other fascinating thing is that the World Wide Web Consortium, otherwise known as W3C, is also assisting us in that we have their experts working in something called the semantic web aspect of digital use of FHIR. So this is a really exciting opportunity. There's a lot of interest, and we're reaching out, frankly, as this evolves, to be sure that we have our fairly broad application base and understand the nuance of that. Our intent is that we will have a balloted, so in the HL7 context, the members look at even draft proposed standards, ballot those in terms of their suitability. There's a resolution process around the ballot, and we're hoping that we will be able to have a draft standard for trial use in the HL7 domain to be published by March 2014. It will support content for the consolidated clinical document architecture. Now, if you've been following what's been happening, particularly in the U.S., there was a lot of work around the standard clinical document architecture by HL7, and now there's been a consolidation of that work, and that is being used as a foundation for much of the health information exchange interoperability in the U.S. So this first draft standard will be able to support that, and that's our primary focus. We expect over 2 to 3 years that there will be iterations of that draft standard for trial use before there's a first normative version. So we have lots of implementation experience before we actually declare this thing normative. It's just that new, and so we'll be able to prove that. Interestingly, and I think this has a lot to do with the compact nature of FHIR, but also I think because this area offers greenfield opportunities in deployment, is the use of it in mobile applications. Now, FHIR is in no way limited to mobile. I need to stress that. But it's that the mobile community seems to have seen an opportunity, and they are looking at this for sure. I'll give you an example. Some of you may be familiar with Mohawk College. They are based out of Hamilton. They have a thing called the Mohawk Applied Research Center for Health Informatics, and they've actually developed the OS libraries for a little instance of FHIR as it exists today. So they will produce product that will be able to be readily used in that context. That's one example. So the other thing that we need to stress is that eventually, as this goes on, FHIR does have a potential to subsume some of the existing V2, V3 messaging and CD specifications. It is meant to be not collide with those, but rather to allow sort of a nice, elegant transition into the sort of a simpler implementation format over time. However, that transition won't be rapid where there's already significant investment, and certainly Canada has invested in V3 significantly. So, the HL7 V3 messaging and document paradigm is not going away anytime soon in Canada. FHIR does address several issues that implementers have been experiencing with V3, however, so that's why it's of interest to them. The information between V3 and FHIR should be relatively straightforward. And, for example, one of the other things about the Canadian context is that the way that the infrastructures that have been designed and engineered right from the outset, in terms of what Infoway is proposed and is being adopted across the country in our investments, is that the health information access layers could expose FHIR interfaces in parallel with V3. So there's no reason that you have to replace a working interface to try out FHIR, and particularly if you're going to start attaching mobile applications to a jurisdictional health information system, for example. And then there's absolutely an opportunity to create pan-Canadian profiles for FHIR. That would need demand from the jurisdictions and the implementers, but I think right now, particularly in the draft stages, more important So you can read the spec at this site. You can follow #FIRE on Twitter. But you can shape the specification. So there's a wiki, which you can also access off the HL7 site, which is linked to the spec. Try implementing it. Better still, come to a Connect-a-thon if you're a vendor interested in this. And you really do want to participate, know more about it. It's still very early days, so probably the best thing to do if you are actively interested is to consider becoming a member of HL7 and coming to the next HL7 meeting, which is in May in Atlanta. We hold these meetings 3 times a year just for your interest. So that's the presentation, and now we'll open up the floor to questions on either topic, either CIMI or FIRE.
Thanks so much, Ron, for another informative question. We are clearly in days with both of these standards, but both you and us have demonstrated there's been a lot of foundational work done by and its partners internationally. So kudos to all of you. To our once again, you're welcome to use the chat function to send questions in, and I will curate them and moderate on your behalf and address those questions either to Dennis and Ron. At the end of this presentation, at the end of the question and answer period, we will have a couple of slides that will give you information on how to access to the presentation that you saw today for the website. And of course, we'll give you a little more information about future webinars and evaluation that we like to conduct with each webinar, because they do indeed assist us with continuous improvement in this series of webinars. That's come in. I wonder, Ron, maybe I'll put this to you, but Dennis, I'll encourage you to add any supplementary thoughts to it. We've heard about the 2 different emerging standards. We've heard a little bit about the contrast between those standards. I wonder if you have some more thoughts on the relationship between CIMI and FIRE.
Sure. I've alluded to this a little bit already. FIRE and CIMI are not, strictly speaking, in conflict, although both of them are attempting to work at a way of defining definitively what the packages are. You know, these small things that we generally commonly reuse, particularly in terms of the way that we speak about our patients in the healthcare system and what we do with those patients. FIRE focus expressly is around that trend, the ability to provide for the transport, to encapsulate those things in a simple way. It's very, very developer-oriented in terms of ease of use. The thing about FIRE that would preclude the incorporation of CIMI concept definitions is that it would do that transport. The real question is just a matter of, so what will be the reference model that we will be working from? Today, FIRE has derived from a body of experience, a lot of information around the reference information model at HL7, and so that's primarily where that's drawn from. But there's a reason why FIRE would act as a very appropriate transport mechanism for CIMI-defined artifacts.
With Ron and that, and the other thing I would add is think of CIMI as being the clinical requirements into FIRE. So that would be one thing could think of in that context of how they relate to each other. The other thing is CIMI has other uses, and we particularly are thinking of those other uses. So they could be uses such as storage into a database. They could be clinical information that goes into a service call, as I mentioned earlier. It could be clinical concepts, meta-clinical concepts that help inform screen design. So the uses of the models are very broad in our context, but clearly support the needs of FIRE and other exchange mechanisms beyond FIRE.
Question here. Maybe this is for you, Dennis, and of course, Ron, you're welcome to add any supplemental thoughts. Ron did mention a reference model, and the question is in relation to how CIMI relates to HL7's RIM model. Is there a thought that you can offer in that area, Dennis?
Yeah, we've that issue. Our starting point, as I mentioned earlier, is OpenAir, and we are taking the OpenAir reference model and letting components that are useful to us. So it will not be the complete OpenAir reference model that are used in their context, but a subset and maybe to some degree slight modifications to it. So that's our starting point. We'll see a dissonance or disconnect with HL7 RIM, at least with what we are trying to do. So we see there's enough synergy there, and we would hope to see that these models could be used easily in an HL7 context, both in a V2, V3, or in a pure fire context. So all of those would hopefully be implementable technology stacks, if I could use the words I used earlier, that would be targets of these SIMI models.
Great, thank you. Question here, and Ron, this will be one that you can speak to. I'm just going to phrase. RESTful services are not considered very secure. If that is so, how is FHIR addressing the security issues?
So there is a focused piece of work in terms of the security implications around using FHIR, but those generally do apply to REST in general. They're not just specific to FHIR. At this point, the focus has been primarily around the definitions of the resources, with presumption that the community will work with us in terms of describing, in terms of implementation guides and other methods for how to deploy these RESTful interfaces in a secure way. So far, I don't think we've seen any real barriers to that. It's just that it's not necessarily something that's solved inherently in terms of the resource definitions themselves, but rather about what choices organizations make about how they use REST, how they expose those RESTful interfaces to other organizations. And there are lots of methods potentially for solving that, from encryption at multiple places to other mechanisms that can be used. So it's early days. We don't have any recommendations per se that have been described, but I can see that as we work towards, now we know that FHIR works and that we have the basic concepts defined. Okay, how are we recommending that these things be implemented? It would be there that we would start working on those definitions.
Great, thanks. I have another question here, and I know that you've both spoken to examples of how the emerging standards can be used. This question relates to applications, and do you have an opinion around what the best applications, or maybe the emerging applications that would use these standards? What would be some examples of those? And Dan, we'll start with you, and or Ron, want to follow up?
Well, I think I read it earlier. I think probably the most opportunity are those new or deployments, because you have that opportunity at that point when you're developing a new system or a new interface, a interoperability point between, let's say, a mobile device and a system, to make those choices. So rather than changing what is already working, use this in the context of a new system design and or deployment. From a perspective, there's a broad set of uses. So I don't see it would be necessarily limited to any one kind of use, whether clinical or whether a device or type of application that might be used. So I see a very broad set of uses from a SIMI perspective.
Yeah, I'll second that. I mean, mobile is an obvious one because it's very greenfield. Also, it's the thing about FHIR that it is appealing. The resource definitions themselves are extremely compact, and all the RESTful interfaces is well suited to that kind of a platformed environment. But there's a whole bunch of business process as well as supporting infrastructure that needs to be defined to support that, which isn't specific to FHIR or specific to REST, actually, for that matter. So there's a bunch of issues that would need to be resolved. But I will make one observation around SIMI, particularly that is of interest to me, and that is that when you think about things like synoptic reporting, when you think about other things that are being done in terms of analytics is a huge emphasis for us right now, certainly in Infoway, but also broadly in healthcare. And the challenge with analytics has been a lot said about doing language processing and other capabilities, but SIMI offers an ability to link a degree of precision of expression to clinical standards of practice. And that's another huge opportunity. So someone is thinking about an ability to support clinical practice, quality clinical practice, in a way where they're linking the practice to evidence. These constructs, I think, are very, very attractive, and that would be one place where we might be able to find some early demonstrated real material value in their implementation.
And maybe this is a kind of contrasting question. And the question really is there anything here in these new standards that is going to undermine what we're doing now? Starting with Dennis.
No, I think it would be informative to, as I mentioned earlier, either new systems, but maybe quite informative to maintenance of existing systems. If we wanted to make them more functional, for example, deal with new clinical concepts, if we wanted to make your interfaces in those systems, or the vendors do, more structured and coded versus text kind of clinical notes, these models could be very informative to those kinds of maintenance releases.
And we've made choices in Canada, but also internationally, choices have been made around terminology such as SNOMED, CT, and LOINC that are absolutely directly material to both of the initiatives that we've described. There's no conflict there at all. So it's a matter of how we choose to embrace sort of moving forward with the new capabilities and how we choose then to create a roadmap for their implementation. And like I say, in Canada, there's no reason why we can't parallel these things for a while as we sort of work through the emergent standards.
We are almost out of time. I'm going to take one last question, and then we're going to wrap up with that information for subsequent webinars and how to get a hold of this particular presentation. This is one for you, and it's probably more around clarifying. When you started out your presentation, you mentioned open care standards that are the starting point for CIMI. And the third question was, can you confirm that it is indeed open care? Is that the right label, or is it something else?
Oh, open, O-P-N-E-H-R, pronounced open air. So, sorry, should have defined that up front. I believe it's openair.org is their URL, and I'm pretty sure the main wiki that we've stood up for CIMI has a link to it as well. So, O-P-H-R, pronounced open air.
Excellent. Well, thank you again, gentlemen. I think with that final question, we're going to move on to the last couple of informational slides. We want everyone for joining us today, and we look forward to continuing to see you at future webinars. If you could advance the slide deck, Dennis. Great. We will look forward to your feedback. As I said earlier, we do use that in earnest. In fact, we had a review session yesterday from our first two webinars, and it helps to keep us continuously improving these events. We'll be offered to download a PDF of this session upon completion of the evaluation. I'll move us to our next slide, please. A very emerging topic in healthcare, although we have found in our research not a lot of application to date. We do believe big data analytics will be a disruptive technology that the healthcare industry will take advantage of as we move forward. We have completed research on a white paper in this area, and we will be hosting another webinar, although we have yet to find a date. But please stay tuned. If you are part of our email and interchange newsletters, you will receive notice of our next webinar on big data analytics in healthcare. So I'd like to once again thank our presenters and thank everyone for their attendance and their participation and questions today.
Thanks very much.
Thank you, Dennis. This concludes today's web conference. You may now disconnect.